Is it there now? Is it shared now? Hello.
Yes, please. Yes.
Aha. So a little bit. I was talking about general. I was talking about general introduction, and oh goodness, general introduction, and I was saying that if we have a deranged white cell count, if we have if we have a deranged white blood cell count, it is not necessarily a primary hematological disease. And when we see primary, it means it's originating from the bone marrow. We may have an abnormal morphology, but it doesn't necessarily mean that there's a hematology disease. It could also reflect a non-hematology disease. Deranged full blood count will also reflect a therapeutic intervention. All of these things we must be aware of. In hematology, our mainstay is to diagnose anemia and get to the bottom of anemia. So for hematology, anything we do, we want to diagnose anemia. Just think about it. Anything we do in hematology, we have seen anemia and want to get to the bottom of it. And so when you talk about anemia, the causes may be primary or maybe secondary. Usually, we talk about primary disease. When we are told about some of the enlarged spleen lymphadenopathy, especially night sweats. These are some important steps that we need to be aware of if we want to make diagnosis. Some of them don't depend on us. That is why in quality management systems, you want all these things to be addressed. We have to have a good clinical history, drug history, thorough physical examination so that they will tell you whether there's an organomegaly or some of the other things that they can talk about. Age, sex, ethnic origin, social and family history are very important. Social history would include your work history because some of the kind of work, depending on the kind of work you do. For example, we have people who work in paint factory, for example, they are exposed to lead. So when you see certain things, then you know that, oh yes, it is because the person is exposed to lead. So canted basophilia, for example, which we'll come to see later on, is associated with lead poisoning. In making diagnosis, it's a good thing to also know the prevalence of locally existing diseases. If you have knowledge of what exists in a particular area, if you take Ghana, for example, malaria is endemic. So if you have the knowledge that malaria is endemic here, you'll be tailoring your diagnosis to, apart from other things, malaria. All of these things will go to help us determine what subsequent laboratory tests would. Initial screening tests will be a full blood count, followed by evaluation of a peripheral blood film. These are our initial screening tests in hematology. Once you do your full blood count, followed by your peripheral blood film, evaluation, it will point to other investigations that are necessary. And when we come to do workups, you see full blood count first, followed by peripheral blood film. Depending on what we see, we might want to do a bone marrow, or we might want to do coagulation study. Etc., etc. So as peripheral blood film is next to be done. Interpretation of the screening test is very important. One thing you must know is that interpretation of the screening test that we have talked about will come with the limitations of the test. We must know the limitations of the test. So when we do full blood count, you analyze that what are the limitations that you know about. You must be aware of that. We must be aware of variations that occur with age, with sex, ethnicity, and geography, etc., etc. If you take neutrophil count, for example, or even total white cell count, we as Africans have lower white cell count, total white cell counts compared to Caucasians. So this thing has to be known to you. We tend to have neutropenia. It may be cyclical or it may be what you call it, but just the fact that we are black gives us neutropenia. So when you want to interpret neutropenia in a black person, you must be aware that blacks can have neutropenia. So it may not necessarily be a disease condition of like pregnancy and exercise, and we know these are physiological causes of neutrophilia or increase, white cell counts. When there is a problem with a full blood count, it may be qualitative or quantitative. All abnormalities in the cell counts, the cell lines, red cell, platelets, white cells. Abnormalities may be qualitative or quantitative. We should know that. So let's begin with the quantitative abnormalities. If we have simultaneous increase in more than one cell line, then we must originating from a very early cell, a precursor cell. And these are the kind of things that give rise to the myeloproliferative disorders that we know about. Essential thrombocythemia, primary proliferative polycythemia, which is a red cell disorder, chronic myelogenous leukemia, which is a white cell disorder, and ET is a platelet disorder, by the way. And so, if you want to make a firm diagnosis, we'll be looking at which of the cell line predominates. Let's begin with a raise of the cells. So when red cells go up, erythrocytosis, red cell count goes up or increase red cell count above the reference range, erythrocytosis. In the case of erythrocytosis, like I said before, it may be primary, as occurs in primary proliferative polycythemia. It may be related owing to decreased plasma volume. Sometimes it's called pseudo polycythemia. It may be also secondary, which is associated with chronic hypoxia, as occurs in lung diseases, congenital heart disease, high affinity hemoglobin like hemoglobin F, for example, and aberrant erythropoietin secretion. Usually, that will be due to a tumor. Secondary polycythemia is generally excluded when we look at clinical history and physical examination. Because in the primary diseases, we tend to see some of the things we talked about earlier on, the organomegalies. One quick way that can help is to check arterial oxygen. That will help us with the lung diseases. Hemoglobin electrophoresis will help us with high affinity hemoglobin. That kind of hemoglobin, like F, they have high affinity for oxygen such that they tend not to release oxygen, and therefore they create hypoxia. Then the hypoxia leads to the secondary polycythemia. Ultrasound scan and assessment of erythropoietin secretion will help us deal with that, the renal tumors and the rest of them. One key thing that is useful is red cell mass. Red cell mass only increases in the primary disease and not in any of the other diseases. So once you can measure red cell mass, you are good to go. And unfortunately, these things we can no longer, I mean, we don't have the capacity to, so we should build capacity, to be doing these things. These things are done using radionuclides, and our facilities themselves are not well placed to be dealing with radioactive material. So looking ahead, you guys should be able to get us to that kind of a place. Now, quickly concerning full blood count. Hemoglobin, hematocrits, red cell counts are all related by the rule of 3. I guess we know the rule of 3. So if you take hematocrits and you divide it by 3, it approximates the HB. If you take the HB, you multiply by 3, approximates the hematocrits. If you divide hemoglobin by 3, it approximates the red cell count, and that's the rule of 3. Rule of 3 holds regardless of the hydration status of your client. The following will be situations where the rule of 3 would break down. Chronic heart diseases, you will have hemoglobin and hematocrits correlating like that. These are due to factors such as blood viscosity, and salt is a heart condition of TUF that hematocrits is higher than the HB. Never correlates. So if you have a child and you are seeing this kind of scenario, and you even don't have any clinical information, you should be asking questions, because this is what we see in COF. When people wear cardiopulmonary bypasses, they also don't correlate, because the bypasses causes increased hemolysis. When people have post-operative bleeding, the rule of three will not hold. So if you see some of these things on your clinical information that give you such clinical information, then you have to take a second look or a good look at your hemoglobin values and its related parameters. Because from these parameters, we'll go and calculate our indices. This is how hemoglobin relates with platelets. It is inverse. And we see that in iron deficiency due to a chronic bleed. You see hemoglobin is low, platelet count is raised. You also see that in rheumatoid arthritis, inflammatory bowel disease, inflammatory immune responses. So these are conditions where you see your platelets and your hemoglobin having that kind of inverse relationship. Let's come to anemia, meaning that low red cell counts, low hemoglobin. We have done erythrocytosis, increased red cell count. Now, low red cell count translating to low hemoglobin, which we call anemia. And anemia is one thing that is the main thing that we want to take care of. It is the main reason we are doing this. We want to be able to diagnose anemia, get to the bottom of it, because all of the things that happen to us has an impact on the red cell and therefore anemia, whether they be leukemias, whether they be myelomas, whether they be myelodysplastic syndromes, all of that will result in anemia. And so we want to look at how we can classify anemia morphologically. And here we are guided by the MCV and the red cell morphology. And so it gives us broadly microcytic anemias, macrocytic anemias, normocytic anemias. We must bear in mind, and so whatever the situation is, we can classify anemia morphologically like this. Even when it comes to the hemolytic anemias, they are initially classified like this before it breaks down, because the bone marrow is responding or reacting. You may see an overlap, for example, in a dual deficiency of iron and B12 folate, because double pathologies can occur. There are even people with more than one pathology, a lot of pathologies happening at the same time. They call them medical polysources. And so let's begin with microcytic anemia. We all know that it is the commonest of all, and the commonest causes iron deficiency. In iron deficiency, we have low MCV, MCH, MCHC, and normal WBC. WBC count is always within normal, plus a raised REW. I recall one of our colleagues telling us how we can also use the ratio of the MCV to the red cell count less than 13. Is that right? To determine iron deficiency. Once we see these parameters like that, and what a confirmatory test, the first line of confirmatory test will be iron studies or iron profile. As for us in hematology, we like to do staining for iron stores, but because it is very invasive, you want to do that when other things are needed. So that's why we do them when they want to diagnose the primary white cell diseases, the leukemias and myelomas and dysplastic syndromes, etc. Because we still have to do a marrow anyway before we can do that. But if it's ordinary iron deficiency, it is too invasive. You rather go to chemical pathology and have your iron profile done. And when it is iron, then we begin to look for specific causes. We know some of the specific causes are parasitic infections. So we do so-immune examination. We can do so-called blood tests. We can have endoscopy of the gastrointestinal tract. They do what they call dietary insufficiency, USG for females who are adults, postmenopausal, because probably you want to exclude bleeding uterine fibroids. And if they are within menopause, if they are still having their period, you want to exclude heavy or prolonged menstrual bleeding. Those are the things that will lead to iron deficiency. That is why age is very, very important. They tell you a person's age, then your suspicions go wider. You are seeing parameters that speak to iron deficiency, and they say it is a 56-year-old woman, a 60-year-old woman, then your suspicions are more uterine fibroids than any other thing. And so you want to do an USG. When it comes to microcytic anemias, one of the differential diagnoses are the thalassemia, so, or if you like thalassemia, it is thalassemia trait actually. That comes very close to that. In the thalassemia, the difference is that you still have low Ag, MCH, MCV, but this time a raised red cell count. It makes a difference. MCH is normal, RDW is normal. How can we disentangle ourselves? Hemoglobin electrophoresis is there to help us. Measurements of E2 and F. In the past, we used to do that very, very manually. But these days, you can do HPLC. You are modern people. Globin chain analysis will help us. DNA studies will also help us to be able to decide that what we are seeing is thalassemia. And we know that thalassemias are as a result of shortage in the protein chain. So it's quantitative. And so another differential diagnosis for the microcytic anemias are what we call anemia of chronic diseases. Some of them present as microcytic anemia. Some renal diseases do, in fact. And so if you see microcytic hypochromic situation, on full blood counts, on peripheral blood film. What you want to do is that you have to be guided and say that because all of these things are differentials, you can list them. And then you begin to pick out the ones that makes it more iron, or makes it more thalassemia, or makes it more ECD. Sometimes your clinical information will come in handy. And so for the microcytic anemias, you easily would say we are seeing either a thalassemic reaction, we are seeing iron deficiency being the commonest, or we are seeing anemia of chronic diseases. Let's move to macrocytic anemia, where the MCV is raised. If we find raised MCV with over macrocytes and hypersegmented neutrophils on peripheral blood film, then we know we are dealing with B12 folate deficiency. It's a clear-cut thing. Over macrocytes, raised MCV, over macrocytes on morphology and hypersegmented neutrophils. Then we are dealing with B12 folate deficiency. These are some conditions where that will lead to B12 folate deficiency. Bowel diseases, fish tapeworm, tropical sprue. Tropical sprue is a condition where there is malabsorption. It may be due to many factors. Bacteria, parasites, viruses, together with other conditions like contamination of water. It is tropical because it happens to us here. And so when you see these things, they want to find out whether people don't have malabsorption problems, because tropical sprue is a malabsorption problem, as well as these bowel disease and the fish tapeworm. The fish tapeworm, a microbiologist can help us better, And then a good old pernicious anemia can be excluded when we do Schilling's test. And I believe we know pernicious anemia. If you remember the biochemistry of B12, inclusive factor is pernicious anemia. So IF. There are other associations when it comes to the macrocytic anemia. Use in excess alcohol, drugs such as hydroxyurea are able to cause macrocytosis. Reticulocytosis would also present as macrocytes. We see them as polychromatic cells on our Romanowsky stains, whilst we see them as reticulocytes if we do the specific supravital stains such as new methylene blue. Just for information, that because we just talked about polychromatic monochromatic cells. I want us to be aware that that kind of presence is associated with hemolysis and also blood loss. Chronic bleed hemolysis. When we see a combination of red cell fragments, we see a low platelet count, and we see polycythemia, then we should be thinking microangiopathy. And I believe that we have done hemolytic anemias, so we know microangiopathic hemolysis. And so when you see such things, it triggers coagulation studies, renal function, and look for a neoplasm or search for an infection. Why? Because in DIC, disseminated intravascular coagulation is a consumption coagulopathy. So those clots that are formed can lead to microangiopathic hemolysis. That's why I want to do that. Renal function, renal tumors. You can have microangiopathy, the neoplasms. So when you begin to see some of these things, then you begin to do some of these workups. Normocytic anemia. Sometimes, most of the diseases we see that are non-hematological or present as normocytic anemias, like renal disease, some renal diseases do neoplasms, also immune diseases, even subclinical infections. And to top it all, our hematological malignancies are all so classified. All of them are classified initially as normocytic anemias, unless something else is happening in addition, then it can change the complexion. And so blood film, marrow aspirate or trephine becomes very, very useful. Talking about white cells. White cells gone up, leukocytosis. Total white cell gone up, leukocytosis. Neutrophils gone up, neutrophilia. We find neutrophilia commonly in acute bacterial infections, acute blood loss, and hemolysis. We find neutrophilia in intoxication and some therapy, corticosteroid therapy. And when we see neutrophilia with heavy cytoplasmic granulations on morphology, then we should be thinking bacterial infections. Sometimes there will be also vacuolations. That was why when we're dealing with collection and handling of blood, we said we don't want you to create vacuolations in the lab by leaving samples unattended to and later on describing them as having vacuolations. In the absence of any underlying cause, if you see a high neutrophil count with immature myeloid cells on morphology, then your thinking should be CML. Of course, in CML, you see the whole spectrum of myeloid cells as it is described. You can use CML to study maturation series in the myeloid cells, because you see all of them there from the myeloblasts through the myelocyte, metamyelocyte, and the matured forms. Our cytogenetics and our chromosomal analysis will be useful. Chromosomal translocations, BCIBL fusing gene is what we are looking for. When we see dysplastic changes or dysplasia, then we should be thinking myelodysplastic syndrome. About the lymphocytes, we know it's a feature of infection in children. As for children, lymphocytosis, then we are thinking infections. We see them in pertussis, tuberculosis, infectious mononucleosis, cytomegalovirus infection, brucellosis, infectious hepatitis, etc. You see them in all of these benign conditions, and then we also see them in the lymphoproliferative disorders, including CLL and the lymphomas, especially in the elderly. One good thing is that when these things come, clinical manifestations most of the time will give it away, lymphadenopathy. You'll be told, as soon as you see lymphadenopathy on clinical information, then your mind should be tuned to looking out for some of these things. Morphology is useful because, for example, in infectious mononucleosis, you see what are called atypical lymphocytes. And that's not that's not a malignancy. It's a benign condition. Infectious mononucleosis, atypical lymphocytes. If you do your immunophenotyping, it will help us to determine what type of lymphocytes we are seeing, and then we'll know whether we are seeing malignancies or not. Bone marrow aspirate refine are also there for us to help us determine whether what we are seeing are malignancies or not. What they call light chain restrictions, PCR, gene rearrangements are all useful to help us determine the type of population of lymphocytes we are seeing. Protein electrophoresis is a good thing to do. Urine benzoate proteins, I wonder if they still do urine benzoate protein, because it is very diagnostic of multiple myeloma, just as protein electrophoresis is. Sometimes, if you work in a place like Korle Bu, we have at times asked people to go to pathology where they do fine needle aspiration cytology of lymph nodes when they are enlarged. Then they will tell us whether these cells are seen in the lymph nodes are lymphoma cells or non-lymphoma cells. That's the essence of that. So now the monocytes. A slight to moderate monocytosis may be seen or may be associated with some of these, the following, like malaria, like typhus, like rickettsia, and tuberculosis. So you begin to see these on morphology. Then you begin to think some of these things. Looking at the elderly, it may be associated with chronic myelomonocytic leukemia, which is a myelodysplastic syndrome. When it comes to these things, the myelodysplastic syndrome, they are usually accompanied with some of these organomegalies, and there will be other abnormalities in other cell lines also. Myelodysplastic syndromes are associated with deranged cytogenetics. There are a host of them. For most of them, I think there's deletion 5q, I think. Eosinophilia. Eosinophils gone up, typically associated with allergies. Some drug sensitivity, skin diseases, parasitic infections. These are things that we should know. As soon as you see neutrophilia, the common thing that should come to you will be parasitic infections, depending on the scenario that you are given. Allergic reaction, drug sensitivity, etc. Skin disease because they tend to carry. That's why I said most of the cases can be ascertained from the clinical history. And so sometimes in the beginning we said that, oh, travel history, medical drug history, that all of these are very, very important. If we suspect parasitic infections, of course, through RE, urine RE for parasite over is a point of call. There is this thing called HES, stands for hypereosinophilic syndrome. It is also a cause of eosinophilia, and it is idiopathic. One very bad thing about it is that the granules, once released, can cause damage to tissues of the heart, lung, etc. With pedophilia, you should be worried to see whether it is not HES. The counts are very, very, very high. Eosinophilia is also a finding in chronic myeloid leukemia. Basophils gone up, basophilia. We usually don't have basophils going up like that. If you find basophil gone up on your full blood count, you must take a second look at it, a careful look at it, because if you remember, it is between 0 to 1%. So if you begin to see a lot basophils, then your attention must be drawn to, by all means, evaluate a field and assess whether it is not CML. Because if it is indeed CML, other things would show. Indeed, in CML, increasing basophil count suggests transformation to a more malignant cause. So in the chronic phase, basophil count is lower than in the isolated phase. And then the blast phase, So if you see basophil count going really like in CML, then it means that it is transforming into more aggressive or more malignant cause. Let's talk about leukopenia. Total white cell count gone down translates into low neutrophil count or reduces neutrophil count. The first thing you have to do is to exclude physiological variations because there's what is also called familial neutropenia. There's neutropenia, it goes and comes. So like first time full blood count, neutropenia, you don't run away with it. You have to do it another time and see whether it is still there, in which case it is not cyclical. Then there's the one that has to do with ethnicity. Black people, we tend to have low neutrophil counts. So now let's talk about low white cell count translating into leukemia. Neutropenia, for example, will occur in overwhelming infections. They are what we call overwhelming infections. They are bacterial infections, but the individual and his immunity is unable to cope. And so, most of the cells you see will be banned neutrophils and metamyelocytes. So then you begin to talk about leukemoid blood pictures. So oid in pathology means like, it's looking like leukemia, leukemoid. You also get neutropenias in these autoimmune diseases like systemic lupus. When you're looking for the neutrophils, they'll be busy trying to go and engulf the the destroyed cell that has been attacked by the antinuclear factor or antinuclear antibody, and then therefore they will not be there to be counted. It's why we get neutropenias in SLE. We get neutropenias when people are being treated with radiation and myelosuppressive drugs, cancer treatment. Yeah, you get it. Bone marrow examination will be useful for us to know whether there is peripheral destruction or stem cell failure, because there are conditions like the autoimmune diseases where you see the bone marrow and you see, oh, myelofibrosis is orderly, then you are thinking that then very likely the cause
Okay.
Hello, am I back? I was lost. Hello.
Hello.
We can hear
We are
you.
lost too. We are lost
Am I
too.
back?
No,
Yes,
please.
please.
Your screen
Am I
is back, but not the slides. We can't see.
The
We can't
slides are not
see.
back. Eh?
We can't see your
Oh,
slides.
okay. Yeah, give me 1 minute. You see. Hello, is it okay?
It's okay. It's okay.
Yeah, it's back.
Are you seeing now, please?
Yes,
He's back. He's back.
You are seeing now, are you?
Yes. Yes.
All right. I was lost when I got back. Then I'm using a phone. I tried to use a laptop, but the connection was difficult. So I'm using a phone. So it's also not easy. So if I'm back, then let me continue.
Okay.
I talked about the fact that, so we are talking leukopenia now.
Yes.
And I talked about overwhelming infections. I talked about SLE, radiation and cancer drugs, etc. And I said that, okay, and I said that BM aspirates will help us determine whether this thing is peripheral or it is a distraction, or whether there's an actual problem with the bone marrow. And then we got to Cosman syndrome, where there's also neutropenia. Why? Because there's maturation arrest at the pro-myelocyte stage. And so it translates into neutropenia. And so Cosman syndrome. Let's talk about all the rest of the cell lines when they are reduced. All of them are reduced by stress. So like surgery, like trauma, like infection. For example, lymphopenia may appear in HIV, in renal failure. Monocytopenia may typically be found in hairy cell leukemia. Hairy cell leukemia is associated with with a pancytopenia. And so when you have pancytopenia on full blood counts, and you have peripheral pancytopenia on peripheral blood, one of your thinking, one of your differentials will be hairy cell leukemia. Anything that will cause the things that will cause all the rest cell lines to be reduced. So we talk about platelets a bit. When platelets go up, is thrombocytosis. Platelets go up is associated with infectious and inflammatory conditions like osteomyelitis, rheumatoid arthritis. If you remember, I said in practice, there's an inverse relationship between hemoglobin and platelet. You find hemoglobin low, but there's thrombocytosis. Some cause thrombocytosis include chronic blood loss, chronic bleed, as happens in iron deficiency. When there's a bleed, obviously because platelets they have a primary function of hemostasis. They want to come and see whether there's a problem to solve. That is why they come plenty. You see thrombocytosis in red cell destruction. You see thrombocytosis when people have been splenectomized. So red cell destruction, splenectomy, you find in sickle cell disease, especially when they are auto-splenectomized. You see that they have high platelet count, sickle cell disease patients, and when they are immunizing too, they tend to have high platelet count. We can have thrombocytosis also after bone marrow suppression, and the bone marrow is coming back. They call it rebound. We can have thrombocytosis in essential thrombocythemia, which is a myelodysplastic myeloproliferative disorder. And in ET, the platelets are also large and bizarre looking, and the count is very high, and they tend to give us thrombotic and bleeding complications. And so, as again say, thrombocytosis that occur in chronic blood loss, they will be very small platelets, or more like about the same size compared to essential thrombocythemia, where the platelets will show an isocytosis. And on morphology, some will look very, again, bone marrow examination and cytogenetics are paying a lot of attention because it is speaking to us that it's a common isolated finding in the lab. Anytime we find thrombocytopenia in the lab, we must make sure that it is the actual case of thrombocytopenia. It's a true reflection of the situation, because artificial thrombocytopenia comes in different forms. Microclots in the specimen, platelet clamps, platelet saturated, and good old DDT, we have said, has some effects of clamping on platelets. And so we find low platelet count, we ought to be very sure that it is coming from the sample and not from anywhere else. A true thrombocytopenia we see when we encounter ITP. Certain drugs can also cause thrombocytopenia, and that is why we need to be told about people's drug history. Sometimes they are not told some of these things, and so when we are evaluating the field, we want to be asking some of these things, querying that we are seeing thrombocytopenia. We can see an apparent cause? Is it that case that the person is on what kind of drugs, or is it the case that it is drug related? And then you are asking whether it is drug related. We may see thrombocytopenia in myelodysplastic syndrome, in thrombotic thrombocytopenia purpura, as the name suggests, hemolytic uremic syndrome. We see thrombocytopenia in acute leukemias as well. We see thrombocytopenia in what is called HELLP syndrome. Means we are seeing hemolysis, we have seen elevated liver enzymes plus low platelet count. And then we also see thrombocytopenia when people binge on alcohol. And I think that's why when they fall into the gutters and they get hurt, they bleed a lot. Alcohol binge. Bone marrow examination is always there to help us to determine whether we are seeing a myelodysplastic syndrome or an acute leukemia. And then we are free to make other deductions if we don't see them as such. Thrombocytopenia is also a common finding in P. falciparum malaria. Let's quickly look at the qualitative abnormalities so that we can put all of them together at a certain time and see what we can do. In health, like you all know, only matured forms of the cells will appear in peripheral blood. If you know your maturation series of the different cell types, you know from where to where should be in marrow, from where to where should be in peripheral blood. Immature cells like euchromatic cells, myelocytes, metamyelocytes will come into peripheral blood when the marrow is overreacting. And so the marrow is functioning abnormally. There's hemolysis. Bone marrow is recovering after rebound. You see some of these things coming. Otherwise, only mature forms should appear in peripheral blood. Therefore, if we see non-mature forms appear in peripheral blood, then we have an axe to grind. Beginning with the red cells, and later on we'll look at the different red cells pictorially. So there are congenital abnormalities of red cells, they go to affect the structure. And so we'll be talking about spherocytosis, elliptocytosis, for example. There are congenital abnormalities that also affect the red cell content. And so we mentioning the hemoglobinopathies and the enzymopathies. As for the enzymopathies, the commonest one we'll be talking about is G6PD deficiency. The next one is pyruvate kinase deficiency, although it is rare. Although there are a lot of other enzymes in the glycolytic pathway, these ones don't happen. The ones that happen are just the ones that I have talked about. Congenital abnormalities of red cells may also produce typical morphological changes, as we'll come to see later on pictorially. Tissue electrophoresis enzyme assay are all useful for us to arrive at a diagnosis. When we see target cells, they may trigger a liver function test. Not just liver function test, since you can also see target cells in, say, iron deficiency and also in the hemoglobinopathy. When it comes to the red cells, something else that we have to know is called the arrangement. When we are evaluating fields, the red cells are supposed to be discrete, just touching one another. And that is the morphology zone we'll be talking about. If we see rulo, then it is indicative of something, especially muscle myeloma, massive rulo. You may see rulo also in some conditions as rheumatoid arthritis. And looking at these things, you don't just see rulo and arrive at multiple myeloma. If indeed it is multiple myeloma, there are other things in the white cells that you see. You see lymphocytosis, for example. You see specifically plasma cells when you do a bone marrow aspirate or trephine. Looking at the white cells, congenital anomalies of the neutrophils are not common. They are there, but they are quite unusual. You can talk about the Meheadlings, the Rallies, the Chagiaki, Pelgaviate, etc., etc. They are not too common, but we'll look at some pictures when it comes there. But we see Pega cells in myelodysplastic syndrome because of dysplasia or dysplastic changes. We see reactive lymphocytes in infectious mononucleosis. As soon as we see atypical lymphocytes, our thinking is infectious mononucleosis. You want to confirm with heterophile antibody test, also called Barnell test, because Epstein-Barr virus is a culprit. You want to find out serum titers of EBV antibody. We will also do a bone marrow histology. It will help us determine whether the mononuclear cells that are circulating are lymphoma cells. Immunophenotyping, gene rearrangement, distribution will also help us to arrive and see whether we are dealing with T lymphocytes, B lymphocytes, etc., etc. Because on our Romanowski stains that we do, we are not able to determine and see that this lymphocyte we are seeing is T lymphocyte or you are dead cells, the cells that we are killed by dying them. We have killed them already. There's no way you can see. Again, about the white cells, and these things are what keys we're using to determine whether a white cell is primitive, that is immature or matured. The primitive ones are said to have high nuclear cytoplasmic ratio. What does it mean? It means that you see a large cell with a large nucleus. That is why your analyzer, if it is not programmed to count immature cells, will count all of them as monocytes because they will scatter light in the same manner as a monocyte. And so don't be surprised when your monocyte count goes up and you come and evaluate the film and you are seeing rather primitive cells because the analyzer determines, like we have been told the other day, light scattering, forward scatter, side scatter. Forward scatter determines size, side scatter determines content. And so, according to the analyzer, a primitive cell will scatter light the same manner as a monocyte, and therefore it will categorize it as a monocyte. Cytoplasm deeply mesothelial, bluish cytoplasm is deep blue. If you see deep blue cytoplasm, you ought to be thinking a primitive cell. If you see the presence of nucleoli or nucleolus, you ought to be thinking a primitive cell. So when it comes to the white cells, these are the keys that we shall be using. When it comes to the red cells, we know all of them already because we have run through them, like the size of the red cell, the color of the red cell that determines the hemoglobin contents, MCH on full blood counts. We'll talk about whether there are inclusions, and then we talk about the shape of the red cell also. We talk about the arrangement of the red cell. That will bring us to talk about whether we are seeing rulo or whether we are seeing agglutinates, platelets. Poorly functioning platelets will not necessarily appear morphologically abnormal. You see the platelets as they are, looking like normal platelets, but their problem is with function. The ones that have aberrations in their morphology are the giant platelets or large platelets. And I remember we see giant platelets in a coagulopathy, Bernasoli syndrome. And so when you see these things, you want to test, you want to do the coagulopathy test for coagulation studies, and also platelet function tests. When you see these ones, the function tests are prolonged. Their function tests are abnormal, and these are characterized by prolonged bleeding. The platelets don't function well. The result is that people bleed excessively. In all of these things that we have talked about, one thing we should know that is very, very key is that we, as lab scientists, must be of a certain quality. If we lack that quality, some of these things will be lost on us. Our knowledge and the skill that we have becomes very, very crucial. quality management systems becomes or should be a way of life. Internal quality, external quality, very necessary. Breaking it down, pre-analytical, post-analytical, very crucial. That is why we began by looking at collection and handling of our blood, because if we make mistakes over there, then we are asking for trouble for ourselves, because things that can appear in pathologies, we would have created them as a pre-analytical stage. And are we justified to create them and say we are seeing a pathology? I don't think so. I thank you for listening. If you have questions, let's answer them. Questions, please. It's time for questions. Yellow, it's time for questions. Yellow, if you can hear me, it's time for questions.
Yeah, we can hear you.
Yeah, please. So these are the little ways that we use the full blood count to make diagnosis. And then we employ peripheral blood smear. Depending on what we see, it will point us to further tests. So our screening test will be our full blood count first, followed by evaluation of the film. So we must learn how to evaluate film. We want to evaluate film, we must understand the full blood count result. We pick our red cells on morphology. We want to describe them and see whether the size is small, big, or larger than normal, or normal itself. And then the different scenarios keep flooding into our heads. Whether the color of the red cell is adequate, and then we talk about whether it is normochromic or it is hypochromic, or whether there is no central color as occur in serocytosis and in macrocytosis. We are looking at the shape of the red cells. Some of them are congenital, some not. Indeed, genetic bramble. And so we look at the shape of the red cells and learn the different shapes of the red cells and try to put them into perspective. And then we look at contents of the red cell. Red cells don't contain any other structure. If you see any structure in the red cell, then you must address it. So like you see a nucleus there is not a normal site. It's a nucleated red cell or a normal blast. You see remnants of RNA is a reticulocyte. If you do your supravital staining on your Romanowski, they would appear as polychromatic cells. And then you speak to it. Excuse me. You see, the red cells contain anything at all. And the red cell can contain, say, malaria parasite. That's why when you see malaria parasites within the red cells, you say a person has malaria. we'll look at some of these pictures, and then we see, say, basophilic staplings, etc., Cabot rings, etc. We'll look at those pictures and we'll try to see if we find these things, what do they mean to us? And then we look at our white cells. The numbers are important, like we have discussed. The numbers, whether they are high, whether they are low, they are important to us. We speak to them. And then we speak to the white cells qualitatively as well by looking at NC ratios, color of cytoplasm, and then presence of nuclei. Indeed, in benign disorders of white cells, there are also some inclusions, because we find bacteria in white cells, in what they call Dolly bodies in neutrophils in the bacterial infections. Some of these things will also come up. Are we good? I'm not getting responses. Says, hey, there are ladies too, ladies and gentlemen. And so what I'll have a discussion with my colleague, and then we'll see whether we can send questions.
Hello.
Yes.
I have a question. We know.
You are not audible properly, sir.
Hello.
Yes.
Is it okay now?
Oh.
Please, is it okay now? Hello.
You talk, let's see, because you are not coming out too clear. But
Okay,
continue, if I'm able to pick it up. If anybody is able to pick it up, they might repeat and I'm out here.
During the rest of production, I know that there are other metals involved, which is copper and then zinc. But it seems we mention of iron deficiency, or the others are not really of any.
Oh, there are, you know, sometimes you want to look at what limitations you have. Have you, do you know, do we have the means to be checking these things? Well, what we are able to do easily is what we have talked about. But there can be zinc deficiency, why not? There can be copper deficiency, why not? There can be, you know. And so when we talked about the iron thing, we said the commonest cause of microcytic anemia worldwide. It doesn't mean there can't be any other deficiency. There may be deficiencies, but what we are trying to learn, what we can and what we can demonstrate. All right. And so some of these things, you may have even read more about them than I probably have. So in my little corner, I'm trying to see whether we can begin small. If we begin small and we're able to diagnose iron deficiency on morphology, this on morphology, that on morphology, won't it be better than talking about copper deficiency. The essence of what we are doing is to be able to diagnose morphologically hematological conditions. That's why we don't want to talk about things that are not close to us. They are not also even common, but they are there. Can you hear me, please?
Yes, please.
If you are not satisfied, then maybe some of my other colleagues can come in and satisfy you. Hello, I want to hear voices. I'm not hearing voices. Yeah, hello. I want to hear voices.
Yeah, there we are.
Because I'm not hearing anything. You see, I'm you know, I'm looking at ability to do the simple things. You see, so things that we can relate to. I really what, because this thing is about morphological evaluation of smears. And so I'm talking about things that are very relevant to morphological evaluation of smears. That's why I'm probably not detailed enough, because if you see we do all of these things as if we have come back to school and we are, or there are too many things that we can talk about. And so I'm looking at things that can help us arrive at, and we hope that by the end of the course, our participants would have learned how to evaluate smears morphologically. I mean, peripheral blood smears. So that is our intention. Look at examine the smear and be able to speak to the smear such that you're able to see that the full blood count result that has been presented is flawed. It has a certain fault, because we know about limitations of the analyzer. For example, because counting is by impedance of particles, you may have a situation where there's a condition like red cell fragmentation syndrome, where red cells are being broken down into very small pieces, and then they no longer fit the size of a red cell. And then they are counted as platelets. And then they go to affect the platelet histogram. Because of their sizes, they'll be seen as large platelets. So we are looking at things that we want to relate to very, very easily. And then from there, we can climb up if we want to. But the essence is to be able to evaluate films, not just describe the red cells are, oh, these red cells are normocytic and normochromic. The white cells are normal. The platelets are normal. Then you end. That's not what we want. We want a situation where we say red cells are normocytic, normochromic, platelets, white cells appear morphologically normal. Platelets appear adequate on the film. It matches a certain condition. Maybe they have a full blood count results with what we see. And then we can see we are seeing essentially a normal blood field. But if you are seeing them that normal and your full blood counts have low counts, then certainly you can say it's from a normal person. Something is the case. And what is the case are some of the things we have just talked about. And if we have the opportunity of being given some clinical what we have found, and then we come to a conclusion. And so probably when we do what I term workups in hematology, you come to appreciate some of these things that we have talked about, because workup in hematology involves the different things that you do to arrive at a diagnosis. If you have a clinical scenario, for example, someone takes a child to, a mother takes a child to the clinic. The clinician sees, certain features of anemia and sees this, and I've asked a few questions, and they probably live in my village where toilet facilities are not adequate, and therefore they are easily exposed to parasitic infections. Some of these things will come out. So from the clinical history you are seeing, what do? You do your full blood count. What would you expect to find? What would you expect to find on peripheral blood? What are some other tests you want to do to make a confirmatory diagnosis? So like I said before, when we are doing tests everywhere in science, I remember when we're doing science, there are preliminary tests and there are confirmatory tests, right? So you are looking at scenarios and trying to arrive at a diagnosis. If you're able to do that, you can now translate them into your work. Because if you see clinical scenarios and you're able to speak to them, it's the same thing you'll be performing at work. Anytime you look at full blood count, you are looking at the full blood count results with a certain mindset. What is the meaning of this? What is the meaning of that? Is it artifactual? Is it not artifactual? And then, they say a child or an infant has TOF, and you are seeing hemoglobin and hematocrits don't correlate. And then in TOF, yeah. Perhaps if we do the next one about workups, if I bring some of the things I'm saying out. But these are the things that you need. These are the keys that you need. So once we do, looking at the pictures now, what does a normal red cell look like? Why do you say this is a normal red cell? Why do you say this red cell is normochromic or hypochromic? Why do you say this white cell is immature? Or why do you say this white cell has gone up? You can estimate the counts of the cells on peripheral blood as well. But because of the analyzers are highly precise, most of the accounts won't dispel, and we really want to be sure. If you have a thrombocytopenia, for example, you can estimate platelet counts. The platelet counts that is giving me, and then we can have a discussion on what is wrong and where the error is coming from, and all that. Probably UDT effects, because there are some clumps somewhere, and that's why the analyzer is not picking the clumps, and therefore the count is lower than that is on peripheral blood. So all these things can be done. Today, they are not asking questions. Today, perhaps when we do the other one, we might, because we are getting closer to using these things to evaluate smears. That's what we are doing. We are etching closer to that. Someone wants to say something. I can hear whispers. Someone saying something. All right. In the absence of any I can hear a voice, please. Is a voice I hear addressing me, please? Is a voice I'm hearing addressing me, please?
No, please.
Okay, CPD consult, please come in.
Mr. Aloti. Hello, Mr. Aloti. Can you hear me? Hello?
CPD consult, if you can hear me, please come in. Oh.
Yes, I can hear you.
I can hear you,
can
yes.
You hear me?
Yeah.
Yeah.
Yes, I can hear you.
Okay, yeah. So I think so far so good. Today has been good. The network has been quite stable.
Yeah, it's been quite stable. Yeah.
Whatever you did to give us a good or a stable network, we want you to continue with it in our next lectures.
Yes, hopefully.
Yeah. And
Yeah, hopefully.
all right. So apart from that, there are no any announcements. Thank you so much for today.
All right. So we'll look at the next thing we'll do will be to look at the workups. You know,
Okay.
a few of the workups. I'll be in touch with Victor, and we'll see whether we can put together some questions.
Okay.
All right.
Meanwhile, the quiz
so that we
I
can
shared
post
with
those
them, the
questions.
deadline is this Sunday. So we hope that students would attempt those questions and then
Yeah.
give them
So
feedback on.
all right. So we'll give them some more.
Okay.
Some more questions.
Okay.
You know, sometimes
All right.
I want to give them questions ahead of the presentation, like things that we haven't done. They should first answer them, and
Okay.
when they make those attempts, and you talk about these things, they might be able to grasp
Appreciate
it better.
them.
That's my thinking anyway.
Okay. All right. That's fine.
All right. Yeah.
Thank you.
All right. Thank you. Father. Good night.
Goodness.
Some glasses.